Welcome to the Student Nurse Exchange Pharmacology Module 1, Applying Pharmacology Basics to the Nursing Process. This module provides a simplified explanation of the core concepts that you learn in your pharmacology class in your curriculum. The second module provides case studies, which uses all the information, and the third module has Nclex style questions that are application and analysis questions that will help you on exams. The two main principles in pharmacology are pharmacokinetics and pharmacodynamics. Pharmacokinetics is the processing of the medication from the entry point, whether it be the mouth, as in when we give pills or liquid, the vein, if we give an IV push medication, or IV piggyback, continuous drip, the muscle, when we give vaccines or other medications, the lung when we give breathing treatments, or the skin when we put on patches. So that's the beginning point of the route. Now it has to get to the bloodstream and all the processes involved to get the medication from the mouth and into the bloodstream, to move the medication throughout the body and eliminate the medication in the body are all pharmacokinetics. Pharmacodynamics is really how that medication, once it's in the bloodstream and you have to create an action, the mechanism of action, such as in the slide showing vasodilation. We want to lower blood pressure, so we give a medication that dilates the veins. That's looking at pharmacodynamics, the mechanism of action. So first, we're going to talk about pharmacokinetics and all the different subcategories in that division of pharmacology. Step 1 in pharmacokinetics is absorption. Absorption is defined as the movement of a drug into the bloodstream after administration. Many things can affect absorption. The rate it dissolves. Some things are enteric coated and meant to dissolve slowly, so it's going to delay absorption. But if we gave an elixir, it's already dissolved. It's going to absorb in the stomach much faster. Other things that can affect absorption of oral medications, how much food is in the stomach or not in the stomach. That's going to affect the pH, and it's also going to affect the breakdown of the medication. It can help. Some medication needs food to be in the stomach so you don't get nauseated. Sometimes you need it to be empty so it doesn't break down too fast as if your stomach was breaking down food. So all those things can affect dissolving of the medication, and then the medication can be absorbed into the body. The routes and the circumstances of your patient need to be considered when you're thinking about processing or absorption of medications. For example, the picture there of the stomach, that's a bariatric patient where the stomach is bypassed. So if you give a medication by mouth and it doesn't even go to the stomach, that could either speed up or slow down the effect of the drug. If normally the stomach is considered in the availability of the drug, then it's going to be less because not as much is going to be broken down. That medication is going to be active right away when it gets into the small intestine. Or maybe the medication will be less active because it's enteric coated or harder to dissolve. So it's going to get into that small intestine and travel further down before it gets into the bloodstream. IM or IV medications, you don't have to worry about the stomach or intestines. They're going to go much quicker into the bloodstream, so the effect is faster. And sometimes we want the effect to be faster, and we know that. So we give the medication IM. Or we give it IM because the stomach acid would destroy the medications. I think a good example of this is insulin. Insulin is given sub-Q or IV if it's regular insulin because the stomach would destroy insulin if you took it by mouth. So that's why it can't be given in that route. It has to be given sub-Q or IV. The other mechanism is inhaling medications. The capillary membrane between the lung fields and the alveoli and the bloodstream is very close and very permeable. So when somebody inhales medications, they're going to get into the bloodstream right away. But think about if your patient has pneumonia or atelectasis, that whole permeable membrane is going to be affected and it could delay the medication effect. So when you're giving medications to your patients, you want to think, how quick do I need the medication to act? Is there anything in the route I'm giving it to and what is wrong with my patient that's going to affect the medication's effectiveness? The term bioavailability is really a term that indicates the percentage of absorbed drug that reaches the circulation. High bioavailability means that more drug gets into the blood. So sometimes when you're looking up medications in your drug references in clinical, or when you're taking care of patients, you want to look up the bioavailability. How much of it actually makes it to the bloodstream and is in its active form. Okay, the next step we're going to look at with pharmacokinetics after absorption is metabolism. We've all heard of metabolism. It's the breakdown of the drugs. And usually metabolism occurs if you take medications orally mostly. You have different enzymes that are involved in the breakdown of the medication. Some people are fast metabolizers or slow metabolizers, and a lot of times it's all about what their enzyme system is. So metabolism, normally you take an active drug and a certain percentage of that drug is going to become inactive. There are other kind of drugs called prodrugs, and these are taken in their inactive form and they become active. I think an example of this would be phosphenotoin, which is a prodrug of phenytoin or dilantin that's used for seizures. And because the medication is destroyed or there's not a big bioavailability by mouth, or say a patient is having seizures and you don't want to wait as long as it would take by mouth, you can give phosphenotoin IM. It might be difficult to get an IV started in these patients, right, if they're having a seizure. So you can give phosphenotoin IM and it becomes active once it gets into the bloodstream. It becomes phenytoin. So that's an example of a prodrug. So metabolism, the breakdown of drugs. The normal route is active drugs, and a certain amount is going to be inactivated. We have the cytochrome P450 is the name of the enzyme system. Some people have more efficient, and some people not as efficient. The elderly and newborns, I think you have to take that into consideration. Newborns don't have as many enzymes yet. They haven't developed, so medications won't be metabolized the same. And in elderly patients, their enzyme system starts to break down, so they're not going to metabolize drugs as well either. So metabolism is the second part of pharmacokinetics after absorption. A large percentage can become inactive. Prodrugs start in an inactive form, become active, and that enzyme system, the cytochrome P450, which usually about 50 enzymes in that system, plays a very active role in the breakdown and metabolism of drugs. This slide is looking at really the metabolism of the liver. The liver is one of the main organs of metabolism, especially with PO drugs or drugs taken by mouth. They have to go through the liver before they can get into the bloodstream. So it went into the stomach, it was absorbed via the portal vein into the liver. Now the liver can metabolize that drug and remember make an active drug into an inactive drug, and how effective your enzymes are can make a big difference as how much of the bioavailability of the drug in the end occurs. This is called the first pass effect. So some drugs that have a high first pass effect really don't have a lot of active drug left after they metabolize through the liver. So it's really got to be taken into account. I think the other thing you hear sometimes is drug conjugates. That's really what the liver turns the drug into a water-soluble drug. A water-soluble drug can then be eliminated by the kidneys. If it's not water soluble and it's lipid soluble, it's going to be stored in the fat. So being able to convert that drug into a water soluble drug, it has to be considered when you're looking at your patients. So all this, the transformation of these drugs and metabolism of the drugs, the conjugating of these drugs, is all in the term biotransformation. So want to consider those terms, the bioavailability and biotransformation, when you're looking at these processes. Okay, the next process we're going to talk about in pharmacokinetics is distribution. Distribution is really once the drug enters the circulation, it's going to be distributed by the bloodstream into either the interstitial or intracellular compartment in our body. Where it goes is really dependent on its mechanism of action and different body processes that we'll go into in a little bit more detail. So the processes involved, also disease states of our patients can affect the distribution of the medication. Every organ or tissue can receive different amounts of medication, and they also stay in those organ or tissues for different amounts of time. So these things are all known about medications and are taken into consideration when we look at drug regimes, when providers order drug regimes for patients. How long will that medication stay in the tissue? How long does it work? That's going to affect dosing of the medication, the route of the medication, and the expected outcome of the medication. Okay, let's look at a couple other concepts or terms or things to think about with our patients in medication administration. So perfusion. So what if a patient has a GI bleed? They're not going to have as much blood volume. They're not going to be able to transport those medications to the tissues. Somebody has low blood pressure. They're not going to have that pressure to move the blood to take the medication to the tissues. Somebody's dehydrated. They're not going to have as much potential blood volume, and that's going to affect perfusion, and that medication's not going to be distributed or go to the tissues or the target organ. Another thing to really understand is protein binding, and that's going to come up in questions on your exam, I could guarantee it. So you have protein albumin. We measure serum albumin, and our patients know what their protein volume is in their blood. These proteins act like sponges, and all medications have a protein binding that's calculated in a percentage. For example, warfarin, I believe its protein binding is 98%. So 98% of that drug, if you have proteins in your blood at a normal amount, is all going to be bound onto these protein globules, and they have little receptor sites on the proteins, and it's going to fill up. Then the protein is going to take it to where it needs to go, and it releases the medication, and the medication can have its effect. But why is this important with our patients? Two things. So maybe they're malnourished and they have a low serum albumin. They don't have as much protein, so that drug isn't going to have anything to bind to be transported to the tissue. It would be considered a free drug or unbound drug, and those are going to have potentiated side effects in the body because they're just unbound and acting on the body in more of a haphazard way. The other thing, if you take two drugs at the same time that are both highly protein bound, they're going to compete for those receptor sites on the proteins, and one of the drugs can be left in a more of a free drug or unbound state than you want it to. So you're going to have more increased side effects of that medication because it's not bound. So if a medication is known to have a high protein binding, you want to look to see if your patient has adequately nourished. Do they have a normal serum albumin? And if you're taking any other medications that are also protein bound, want to take that into effect because it's going to affect the effect of the medication and could change it. The last thing I want to talk about is lipid solubility. So in that little picture is a cell wall, and you have all those phospholipid layer that goes around the cell. It's the cell wall. So if a medication is highly lipid soluble, it's going to be able to slip in through that cell membrane much easier, and that could be an important thing. How soluble is that medication? Another thing about lipid soluble medications, they can be good. They could be stored in your fat cells in your body and released as your body needs it. But what if you have to stop the medication because the effect is not the outcome? It's not causing, the treatment plan isn't working. Well, that medication, if it's still in your fat and stored in the fat cells, it could still be released for a time period afterwards, and that could be not a good thing. So it can work for you or against you. But the lipid solubility of a medication is important not only for it to be able to transfer the cell wall, but also if it's stored in the tissues. Okay, the fourth step in pharmacokinetics to consider is elimination. So how easily can a drug be eliminated from the body? The kidneys are our main eliminator. If drugs are water soluble, they're going to leave that way. If a drug is not water soluble, it's going to be eliminated in the intestines and come out into the stool. And that would be a lipid soluble or a drug that can't be, the liver can't conjugate. What are we going to consider? Things that are water soluble go through the kidneys. So what do we want to know about that patient's kidneys? How healthy are they? Are they an elderly person where their glomerular filtration rate is slowing down? Patients with kidney disease, those medications can't be eliminated as efficiently from the body, and they may have prolonged effects of the medication or prolonged side effects of the medication, or they could be nephrotoxic and hurt the kidneys. So you really want to look at the kidney function of your patients. We're going to talk about some of the lab values later in this module, but looking at things like creatinine, BUN, and the glomerular filtration rate are really important. We talked about drugs being eliminated if they are lipid soluble. They will go through the liver and bile and the stool. So that's lipid soluble medications, really excretion route. Also, some medications you can see come up in other things. For example, the lungs, you may breathe out medication, so a certain amount could be lost or eliminated from your lungs. You have to consider breastfeeding mothers. Some of the medication may be excreted or eliminated from the body in the breast milk. So you have to consider all different routes. There's our lungs, sweat. That could be another one. It's not as high, but it could be lost in the sweat, and our breast milk. So this slide, the kidneys are our main eliminator. They're water-soluble drugs. We have to look at kidney function of our patients, or consider as we get older, the kidney function is going to be compromised. The liver is going to be involved with lipid-soluble drugs. It's going to be eliminated in the bile. The bile is going to go to the small intestine. Those drugs will be eliminated through the stool. A certain amount, although smaller, will be eliminated through the lungs, the sweat, and we also have to consider breastfeeding mothers if any of the drugs could be eliminated and pass into the infant. Okay, two other concepts I want to review quickly are volume of distribution and half-life. Volume of distribution, when you read about it, every drug has a known volume of distribution. It's really not an actual physical volume. It's really looking at the administered amount of the drug to the measurable concentration in the patient's plasma. And it's before the drug is eliminated. The higher the concentration, the easier it will be distributed throughout the body. So it's nothing you have to calculate. It is a measure that is provided, like with bioavailability or protein binding, is the volume of distribution. So again, it's really the administered amount of the drug in milligrams, and then it will equal a certain amount of concentration in the plasma. So it's really something that pharmacologists will calculate with all medications. The other concept to understand is half-life. Half-life is the amount of time it takes to be half of the drug to be eliminated from the body. So it's the time. It's a length of time or duration required to eliminate half or 50% of an absorbed drug. Now the longer the half-life, the longer it takes to get out of the body. So if you take a drug that has a half-life of 3 days, you can expect to have effects of that drug for 3 days. If you have a drug with a short half-life, nitroprusside would be an example. It's a medication we give IV and manipulate on a drip in the ICU to control blood pressure. I can change that dose of that medication and see a change in the blood pressure within really a minute or less, because it has such a short half-life. It's eliminated from the body very quickly. So half-life is something that you really want to know. It's going to really affect the length of time that a drug will be effective in the body and how quickly it's eliminated from the body. Okay, some other terms or things to think about or when you're reading your material on pharmacology. Drugs or receptors can be antagonists versus an agonist. So a drug itself can be classified as an antagonist or agonist, or the receptors that they attach to can be described this way. A drug agonist is when two drugs compete for available receptors and they decrease the effect of one or the other drugs. An agonist, say interaction between drugs, increase the effect of one or the other drugs. Drug interactions is something that I really don't think we look at enough of, but the way that drugs, do they potentiate the effect of each other, or could they antagonize the effect of each other if they're taken together? When you think about it in clinical, we get 10 pills and give them to our patients all at once. The interactions of these medications isn't always looked at as closely as it should be. The other thing to look at is blood-brain barrier. The brain has a protective mechanism built in with its capillary membrane is very tight, and it really prevents the distribution of medications into the cerebral blood flow in the brain to try to protect it. It does make things difficult, though. The medications and treatments for different, like brain tumors, can be very difficult because this blood-brain barrier won't let a lot of medications in. It's a protective mechanism, but also can be a inhibiting factor for treatment in the body for brain disease disorders. Fetal placental barrier is also a mechanism that the body has to protect the fetus. The placental itself is going to not allow certain medications to get into the fetal circulation. Some medications you would want to get in or not want to get in. So the amount of this placental barrier can prevent medications from getting to the fetus would be a known fact with medication.